Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today we have a special topic, which is pregnancy after liver transplantation. So, what we should know. First, the fertility before and after liver transplantation. Second, recommendations of Women's Health Committee of the American Society of Transplantation. Maternal and fetal outcomes after liver transplantation. Management during pregnancy, breastfeeding. What about contraception? And lastly, take-home message. Let's start with fertility before and after liver transplantation. We know that patients with chronic liver disease suffer from anovulation, amenorrhea, and infertility. Why? Due to altered estrogen metabolism and dysregulation of various hormonal pathways. Okay, so there is ovulatory dysfunction in cases with chronic liver disease. But after liver transplantation, most recipients will regain fertility within a year, within the first year. Okay? The first successful pregnancy in a liver transplant recipient was at 1978. This is the first successful pregnancy in a liver transplant recipient. So what about the recommendations of Women's Health Committee of the American Society of Transplantation? One of the most important is to wait at least 1 year after liver transplant to conceive. A recommendation that patients should be on a stable maintenance dosage of non-teratogenic immunosuppression with no rejection within the past year and without any evidence of acute infections that may harm the fetus, like cytomegalovirus, for example. So, it is important to answer the question of the patient, when I can be pregnant, doctor? This patient did liver transplant and she is asking you about when she can be pregnant. You should advise her to avoid the first year after liver transplant. Okay? Second, you should advise her to be on a stable dosage of non-teratogenic immune suppression and to have a chance or plan for pregnancy, no rejection should be at this time or within the past year, or there should be no evidence of acute infections that may harm the fetus, like cytomegalovirus. Should be treated first, then she can do the plan for pregnancy. Okay, so this is very important recommendation. Okay, based on the 2018 Transplant Pregnancy Registry International Annual Report, almost 40% of pregnancies in liver transplantation recipients are reported to be unplanned. Many of these occur early in the post-transplant period, and the both unplanned pregnancy and the pregnancy within first year have been associated with increased risks of maternal and fetal complications in transplant recipients. That's why, you remember when I said Avoid the first year after transplant. Okay, because the maternal and the fetal complications are high at this time. Okay, so avoid the first year of pregnancy after transplant. Unfortunately, 40% of pregnancies in liver transplantation recipients are reported to be unplanned, and many of them occur early in the post-transplant period. So, what about maternal and fetal outcomes? Maternal complications include hypertensive disease, preeclampsia, gestational diabetes. This is the commonest complications that may happen. Placental abruption, postpartum hemorrhage, cesarean delivery, preterm labor, cholestasis of pregnancy, and coagulopathy may occur. Okay? What about fetal complication? Fetal complication include the return birth, IUGR, and the low birth weight, although outcomes are overall favorable. Okay? So overall outcome is favorable, but this complication may happen in some patients. Okay? Let us go to the management. Pregnant transplant recipient should be managed via multidisciplinary approach with the involvement of transplant clinicians and maternal fetal medicine specialists. Okay? And the pregnancy after liver transplantation requires close monitoring of maternal liver function, immune suppressive therapy, and the fetal growth. This is very important. What about medical management? We encourage patient self-monitoring of daily blood pressure, and when hypertension is discovered, whatever gestational hypertension, preeclampsia, the drug of choice is methyl dopa and the calcium channel blocker. Close monitoring of graft function. This is very important, and if rejection is suspected, we may consider biopsy. In cases of acute rejection, steroids are the preferred drug. About the obstetric management, frequent visits, preferably every 2 weeks. So you should see the patient, evaluate the maternal condition, the blood pressure, the fetal growth, the biophysical profile, okay, of the fetus, and also ask for blood glucose or glucose tolerance test because gestational diabetes may happen in such patients. Okay, so good antenatal care is important, and as I said, multidisciplinary team, maternal fetal medicine specialist, and transplant clinician. Next question is, what is the mode of delivery, vaginal or cesarean section? Vaginal delivery is the preferred mode of delivery, and delivery usually delayed until labor onset unless maternal or fetal indication for induction exists. Cesarean delivery is only indicated for obstetric reasons. And be careful when you are going to do cesarean section for a patient with liver transplant and avoid do injury to the allograft, of course. Senior obstetrician should do the cesarean section. The possibility of adhesion is present and avoid injury of the allograft. Antibiotic prophylaxis for all surgical procedures. Increase the steroid dose at labor onset to overcome the stress of labor and prevent postpartum transplant rejection. Okay, what about acute cellular rejection in pregnant transplant recipients? Graft loss as a result of pregnancy appear to be rare. This is good news. Okay, higher rates of acute cellular rejection have been observed in those who become pregnant within the first year of transplant, likely reflective of the overall higher rate of acute cellular rejection episodes in the early post liver transplant period, regardless of pregnancy. So, the possibility of acute cellular rejection occurs more in the first year. That's why we are avoiding pregnancy in such year. Okay? This highlights the importance of contraception and the graft stability prior to conception. So you should counsel your patient about that. Tell her we need to have a contraception in the first year after liver transplant. Then we will give you the plan when you can become pregnant. Okay? So to avoid unplanned pregnancy in the first year after liver transplant, the patient should have a contraceptive method. Okay, what about monitoring of graft function? Frequent monitoring of graft function every 2 to 4 weeks in pregnant liver transplant patients is recommended. It is important to take into account normal physiological changes expected in pregnancy, such as increased alkaline phosphatase released from the placenta and the hypoalbuminemia that happen during the pregnancy when interpreting results. So you should be aware about the physiological changes during the pregnancy. A broad differential should be considered in the pregnant liver transplant recipient with new liver enzyme derangements. If you found suddenly there is elevated liver enzymes, I should do differential diagnosis for such a condition. Is it graft rejection or is it another complication? So, transplant related issue like acute cellular rejection or recurrent primary liver disease, this is one of the differential diagnoses. Or maybe viral infection like hepatitis A, B, C, and so on, E. Pregnancy specific disease such as HELLP syndrome or hyperemesis gravidarum. So I should put a differential diagnosis for, for such new liver enzyme derangements. Why this enzyme is elevated? What happened? Okay. How to distinguish acute cellular rejection or other complication? This can be, in some cases, difficult to distinguish from rejection, although liver biopsy can be safely performed for clarification even in a pregnant patient. So, Of course, liver biopsy is diagnostic. Steroid can be safely used for the treatment of rejection or maintenance. Immunosuppressive agents may be titrated, but the safety of therapies for more refractory ACR, such as anti-lymphocyte globulin, has not been established. What about immune suppression in the pregnant liver transplant recipient? The continuation of safe preconception immune suppression is ideal. So I'm giving certain protocol of therapy of immunosuppressive drugs to the patient with liver transplant, and these safe drugs can continue if pregnancy happens. Okay, like what? Like cyclosporin and tacrolimus, Graf, tacrolimus like Graf, and cyclosporin. So cyclosporin and tacrolimus make up the backbone of immunosuppression after liver transplant. Overall, these agents are considered safe to use in pregnancy. Okay, and you should reassure your patient about that. Maintenance, maintenance doses of prednisone are generally safe to continue during the pregnancy. However, prolonged exposure to high doses of corticosteroid has been shown to be associated with IGR. So, maintaining the lowest effective dose in the pregnant liver transplant recipient is prudent. So, I will give the patient prednisone, but the lowest effective dose. And I'll give the patient cyclosporin and tacrolimus. Okay, both of them safe during pregnancy, and you should reassure your patient. Okay? Can I give during pregnancy mycophenolic acid products like MMF, mycophenolate mofetil? So all mycophenolic acid products are contraindicated because it is highly teratogenic. So avoid this drug if you are planning for pregnancy or the patient is already pregnant. I should stop it if she is taking it before pregnancy and the pregnancy unplanned. You should stop it. But perfectly, you should stop this drug 6 months before planning for pregnancy. Why? Because it is teratogenic. Even during lactation after delivery, you shouldn't use mycophenolic acid products. So this is contraindicated during pregnancy and during breastfeeding. Okay? So patients who desire pregnancy can be safely switched to azathioprine at least 6 months period to planned conception. So I'll give her azathioprine in spite of mycophenolic acid products. Okay? Azathioprine is safe. Okay, what else in immune suppression? Mammalian target rapamycin inhibitors, such as sirolimus, are not recommended during pregnancy due to limited safety data. So, to summarize, what is the immunosuppressive drugs? which can be given during pregnancy. In case with liver transplant, I can give cyclosporin, tacrolimus, which is a Prograf, and prednisone, the lowest effective dose, and the azathioprine. This is the safest drugs to be given. This is the safest immunosuppressive drugs. Don't give mycophenolic acid products like MMF. Don't give mammalian target rapamycin inhibitors because there is limited safety data about it. What about breastfeeding? Can you allow breastfeeding or not? Guidelines from the American Association for the Study of Liver Disease consider the ongoing use of tacrolimus, cyclosporin, corticosteroid, and the azathioprine to be safe while breastfeeding. So, breastfeeding is encouraged in case we are giving the patient the safe drugs, as I said. What are the safe drugs during breastfeeding? Is the same that was given during pregnancy. Tacrolimus, cyclosporin, corticosteroid, prednisone, and the azathioprine. Okay? What about contraception? What is the best contraception in case of liver transplant recipient? IUD. Current guidelines by the American Society support the use of both copper and levonorgestrel IUD after liver transplantation, even in patients who have developed graft failure. These uterine devices have few side effects and provide prolonged contraception. So, IUD is recommended, whatever copper IUD or levonorgestrel releasing intrauterine system. What is the importance of levonorgestrel releasing intrauterine system? Is to decrease the menstrual flow. Has the advantage to decrease the menstrual flow. While copper IUD is sometimes associated with heavy menstrual period. But levonorgestrel releasing intrauterine system carry the advantage over copper IUD in that it reduces the amount of menstrual flow. What about combined hormonal contraceptive containing ethinyl estradiol and progesterone? Like combined pills, like transdermal patches or vaginal rings, all of these are generally considered to be safe after transplant. However, they should be avoided in post-liver transplant recipients who have developed evidence of graft failure, as there are concerns for increased risk of estrogen-associated complications such as venous thromboembolism in this patient population. So, you can advise the patient to take combined hormonal contraceptive in the form of combined pills or transdermal patches or vaginal rings because it is safe. But if there is suspicious graft rejection or graft failure, we shouldn't give the patient combined hormonal contraceptive. It is contraindicated. Why? Because of increased risk of estrogen-associated complication like venous thromboembolism in such patients. Okay? Clear enough? What about progestin only contraceptive? Like progestin only pills or dipomedroxyprogesterone acetate injections and subcutaneous implants like implanon. All of these are acceptable alternatives in transplant recipients, even in the setting of graft failure, as they do not carry the risk associated with estrogen therapy. Okay? So, to summarize, the first choice for liver transplant recipient methods of contraception is the IUD, copper T, IUD, or levonorgestrel releasing intrauterine system. Second choice is to take combined hormonal contraception, either skin patches or vaginal ring or combined pill. Okay? But in state of suspicious graft rejection or graft failure, it is contraindicated. Combined pill or combined hormonal contraception is contraindicated for the rest of venous thromboembolism in such patients. Okay? Due to effect of estrogen. The third choice, another choice for contraception in such patient is progestin only. Pills or dipomedroxyprogesterone acetate injection or subcutaneous implant like implanon. All of these are acceptable alternative in transplant recipient, even the setting of graft failure. Lastly, the take-home message. Pregnant transplant recipients should be managed via a multidisciplinary approach with the involvement of transplant clinician and maternal fetal medicine specialist. After liver transplantation, most patients regain fertility within 1 year, making early discussion regarding reproductive goals and the contraception crucial. So you should counsel her about using contraception in the first year, as I mentioned before. Pregnancy should be delayed at least 1 year after liver transplant with patients having stable graft function on a maintenance dosage of immunosuppression, no evidence of active infection, and no rejection within the past year. This is very important to allow the patient to be pregnant. There is higher risk. There is a higher risk of maternal and fetal complication liver transplant recipients compared with the general population, including gestational diabetes, hypertensive complication, and preterm birth. Mycophenolic acid products are contraindicated during pregnancy due to teratogenicity. Intrauterine devices are an acceptable form of contraception in post-liver transplant recipient, while combined hormonal contraceptives should be avoided in patients who have developed graft failure. I hope it is clear enough. Thank you, everybody. Wishing you all the best. Remember my scientific site. This is in blue, my site on YouTube, where you can find many lectures in OB-GYN, quizzes, case scenario discussion, guidelines, ask stations, and here in red, my site on Amazon, where you can find my published books, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question book, medical disorder in pregnancy, and the gynecologic oncology book. This is my scientific site. Thank you, everybody. Wishing you all the best.